well-known expert in the field of VTE, which is Dr. Will Lester. He's taken time from his busy clinic to present for us. Will is a haematology consultant at the University Hospital Birmingham and provides clinical and laboratory haematology services at the Birmingham Women's Hospital. His clinical and research interests include thrombosis, hemostasis, obstetric, and immunohematology. Amongst other things, he is the Vice Chair of the Hemostasis and Thrombosis Task Force and for the British Society of Haematology Guidelines Committee. Through discussion and case studies, Will be sharing practical steps in VTE diagnosis. So thanks very much, Will, over to you.
Thanks very much for the introduction. I just want to check that my slide's going to move forward. So it should be a title slide, practical steps.
Yeah.
And then a disclosure slide.
Yes, that's coming up. Yeah, lovely.
Fantastic.
Excellent.
Right, let's get going.
Can I just say they're not on presenter mode, if you can put that.
Yeah, I don't know what to do to make that happen.
Joe?
No, I wonder if it's the two along from that screen on your left-hand side. Try that one, maybe. No, I don't know because I'm not sure of the setup here.
But you can see that slide anyway.
Yeah, we can see the slide.
Yes, we can see it.
Okay, let's just go for it.
Thank you.
So I say Beverly's covered this already, and I say on the face of it, you'd think, oh, you know, it can't be that difficult to spot a DVT or PE, but in reality, it just is, basically. And if you ask people to decide whether someone has or hasn't had a DVT or PE, they'll be wrong 50% of the time. And we know that of people who die of PE, over 60% of them have had an encounter with a healthcare professional, and you know, and the symptoms have been put down to something else. So it is really, really tricky. But I'm talking about sort of diagnostics, because Beverly's covered that really well. And she's also mentioned that we have, you know, actually, I think across the UK, certainly England and Wales, you know, with NICE guidance, we have a really, I think, a very consistent way of putting people through the diagnostic pathway. We have a clinical risk score, WELL score. We use a D-dimer. We're told how to utilize imaging. You know, it's all relatively regimented and agreed. And whether your pathway is a primary care-based pathway or secondary care-based pathway, it all revolves around this understanding of clinical risk assessment, laboratory testing with D-dimer, and imaging. And this one's for DVT.
Well, can I interrupt just for a second? Because the slides are small, some people are saying they can't see them. Would you mind if I shared screen and then you just tell me to move on?
Yeah, go for it. Let's do that. Yeah.
Right.
So if you share, and I'll just say move on.
1 second.
I mean, just while you're doing that, in some ways, those slides are, you know, they're taken from NICE guidance. They're not really for you to read all the little bits on them. They're more for sort of to just reiterate the fact that we've got these really consistent algorithms that I think everyone buys into. And it's the same with the PE slide. It's a sort of algorithm which is generally non-controversial, which again for PE and DVT involves the WELL score, the D-dimer, and then the imaging. So I stop sharing. Will that help?
I think your slides are up now. Can you all see the slides?
Yeah. So is that from you now?
Yeah, that's from me. So just tell me.
Yeah. So if you want to progress it. Yep. And I say it's not. Don't worry about the little boxes. Next slide. So you could say, well, I've done my job now. I've talked about diagnostics. It's all pretty straightforward. You know, what's the problem? It's tricky to put people into the diagnostic pathway in the first place, which Beverly touched on. But actually, I think there are issues, and I'm going to talk about, next slide, please, issues that I feel strongly about. I can't talk about everything. I really hope that I can engage you in something. I can teach you something you didn't know already, and that's quite difficult. It's quite a difficult gig with this audience, but I'm going to do my best. So next slide. So the first thing to say is the Wells score was designed for outpatients, for community-acquired events, people coming into primary care or to emergency departments. That's where that clinical risk score was designed. It was not designed for inpatients. And I'm just mentioning on this slide a study looking at, it was single center, but it was prospective, looking at over 1,000 patients being investigated for suspected DVT. And the Wells score performed only slightly better than chance for discrimination of DVT in hospitalized patients, and had a higher failure rate and a lower efficiency than in the inpatient setting than it does in the outpatient setting where it's designed. So there is an argument, actually, it's not really fit for purpose for inpatients, and therefore we're going to have to use our clinical acumen, which we already know is terrible, but it doesn't seem as if the Wells score really adds much to that. And the problem is a lot of inpatients are sick and their D-dimers are up anyway. So I just think bear that in mind. Inpatients, it's not quite so straightforward. Next slide. And the other thing that's been brought in NICE guidance, and I don't know how many people are using this, is this PERC rule, because it's a big thing to put someone through a CTPA VQ pathway. You know, there is radiation in those scans. I'm going to touch on that later. And so they've introduced this concept of the PERC rule, which is a sort of pre-Wells assessment. So you could look at a patient and not even put them into the diagnostic algorithm that we've already looked at if you go through this questionnaire. So you have to be less than 50, not tachycardic, not hypoxic, not with leg swelling, not with hemoptysis, no recent surgery, no previous PE, and not on hormones. The only problem I have with this is it says that you have to think that the likelihood of PE is less than 15% in order to go into this pathway. Now, how a human brain can work that out, you know, we can't say, oh, we think this person's got a 17% risk or an 8% risk. So essentially, I think it's for those cases where you think, I really, really don't think this is a PE. Personally, I'm not entirely convinced about this score, but it certainly is in NICE, and it's something to be aware of. So at the very least, this should be done at the very least, if you're not going to put them into the diagnostic pathway. Next slide. So let's go into a case. This is a 28-year-old who is 34 weeks pregnant. She presents to triage in her obstetric unit with recent onset breathlessness and chest pain, which is made a little worse with a deep breath. Classically, pleuritic chest pain should be on shallow breathing, but it doesn't always work like that. Breathlessness is obviously very common, especially in later pregnancy when the diaphragm's being pushed up. And you're asked to review what investigations do you recommend. Now, that's obviously rhetorical. I'm not going to ask you that to tell me that. Next slide. So this is the first problem we have. Can we use clinical risk scores and biomarkers like the D-dimer? And just bear in mind that we are terrible at spotting PEs in pregnancy. For every 100 people that we put through a diagnostic pathway, we're lucky if we diagnose 5% of them, 1 in 20. That means 95% of people are being put through this pathway to be basically not to have a PE at the end of it. So we're not that great at deciding who doesn't need investigating. So it would be super handy to have some sort of like a Wells score or a D-dimer thing that we could use so we don't expose lots and lots of people who don't have PE to unnecessary imaging. Next slide. But as you'll be aware, many of you, the problem is that D-dimers go up in normal pregnancy. They go up and up and up. In most people in pregnancy have an abnormal D-dimer if you count the out of pregnancy normal range. Of be it 250 or 500 or whatever D-dimer kit you use. Next slide. And people have tried to maybe adapt the D-dimer cutoff. If you could forward it for me. And so one of these is the pregnancy adapted years algorithm. So what they do is they say, well, have you got clinical signs of DVT? Have you had hemoptysis? Keeps cropping up. Or do you think pulmonary embolism is the most likely diagnosis? You know, as opposed to some other pregnancy-related breathlessness. And they use this cutoff of, if you've got no criteria, you do a D-dimer, and if it's over 1,000, you investigate. If you've got one criteria, you can use a D-dimer cutoff of 500, and to do a CTPA or not do CTPA or VQ scan. If you could forward it. And in that case, sorry, in that case, they did stop about 40% of women having to go through the whole scanning procedure with that investigation. But the problem is that in the UK, there was the DIPEP study. Beverly was one of the authors, and they found 12 PEs and 219 women being investigated, again, reiterating the fact that we don't pick that many up. And when they applied that year's strategy, which on the face of it would be fantastic if we could use it, unfortunately, 5 of those 12 PEs would have been missed using that algorithm. So we're still in a situation at the moment where we really don't have a great tool for this group. Next slide, please. So that's problem 1. We don't have the equivalent tool that we have outside of pregnancy, so we end up doing a lot of scanning. Problem 2 is this issue of maternal fetal risk from lung imaging, be that VQ scan or CTPA. And there are these 2 theoretical risks. One is maternal breast cancer from the radiation of a CT scan, especially as breast tissue is changing during pregnancy and perhaps is more radiosensitive. And then there's this concern over fetal radiation and childhood cancer. And if you look at guidelines like the ESC guidelines, you get these tables, which to most of us, maybe some of you, it means something, really is just meaningless numbers. They're tiny numbers that don't mean anything. Because what we want to decide is, you know, is there a risk? Isn't there a risk? What is the risk? And we get faced with these types of details and you know, maybe if you're some sort of radiation specialist, it'll mean something. Most of us, it really is just some tiny numbers. Next slide. So what do ESC guidance say? They say for VQ and CTPA, fetal radiation doses are well below that threshold associated with radiation complications. But this is high dose radiation that is causing sort of, you know, sizzling. You know, we're not talking about we're not talking about cancer risk, we're talking about actual structural damage to a fetus. So that's a pretty big dose of radiation. So I don't think that's particularly relevant. Next slide. But they go on to say that modern CTPA techniques expose maternal breast tissues to very low doses of radiation, and that the effect on maternal cancer risk with CTPA techniques is negligible, basically, absolutely negligible. So avoiding CTPA on the grounds of maternal cancer risk is not justified. Next slide, please. And then we look at our own RCOG guidance. It says women with suspected PE should be advised that compared with CTPA, VQ scanning may carry a slightly increased risk of childhood cancer, but is associated with a lower risk of maternal breast cancer. In both situations, the absolute risk is small. Then it goes on to give some numbers again, which to most of us, as I say, is, you know, I don't know how helpful those numbers are. So we've got all of these different statements by different bodies talking about low risk, and this risk might be slightly bigger than that risk. This is where we're practicing at the moment. This is the environment we're practicing in. Next slide. And then this is an information sheet also provided by RCOG, which we can give to people themselves. It's talking about radiation. It says the X-ray uses a tiny dose of radiation that's not considered harmful, but there is still a small dose. So I don't know at what threshold someone says it is or isn't harmful. But CT and VQ scans both carry a small risk. This must be weighed against the risk to you and your baby of an undiagnosed PE. The risk of your baby developing childhood cancer after VQ scan or CT is extremely low, slightly higher with VQ scan than with CT scan. Unfortunately, this is based on some slightly old radiation data because scanning techniques get better, but that's what it says. That's what someone is reading. And if you were to, I think on the whole, talk to someone who's pregnant and ask them about how they perceive risk to themselves and risk to their fetus, the fetus tends to be given the key importance in terms of decision making. That's just a fact. Next slide. This is a Gary Larson cartoon. It's okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger, stay out of the garbage or else. What does the dog hear? Blah, 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 Ginger. Blah, 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 Ginger, blah, blah, blah. Could you forward it, please? And here's a healthcare professional talking about the cancer risk to the baby. If you could forward it. Blah, 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 baby cancer, blah, blah, blah. That is essentially, I could be honest with you, that is essentially how it can work. Next slide. So what happens if a scan is refused because someone's been told it might cause their baby to get cancer? The problem is we're obliged to treat this as a pulmonary embolism. Therapeutic anticoagulation basically needs to go through the whole of pregnancy and for potentially, 6 weeks to 12 weeks postpartum. This introduces a significant bleeding risk, especially postpartum. It means that every single pregnancy after that will require prophylaxis because we didn't know if it was a PE or not. It means there's a label of suspected VTE in medical records for life, insurance issues, people being treated differently. And we already know that 95% of these suspected events are not PEs. Next slide. And humans are not great at calculating risk. The perception of risk is we're not automatons, we're not robots. We don't calculate things in terms of stats. We have emotional engagement when we talk about risk. And if we talk about a risk, even if it's small, if it sounds bad, if there's a degree of outrage, it will override any talk of tiny numbers, minuscule numbers. Even if you said it's just above naught, it doesn't matter if you've got this degree of concern and outrage about what the risk that you're talking about. And we know that people don't mind risks they choose for themselves, but they don't like risks that are imposed on them, like a scan. We know that adults accept risk on themselves more than they will accept risk on children and, I think, the fetus. And we also know that risks that are natural are more accepted than risks that are unnatural. So this all makes it really, really tricky. Next slide. And so if let's look at some numbers now. I've said the numbers are difficult to understand, but let's look at the numbers in the context of environmental exposure. So the fetal absorbed doses for a VQ and a CTPA are similar and so small that they are unlikely to be clinically significant. That's the first statement that's made by the European Association of Nuclear Medicine. So we start to ask the question, why are we even talking about it? But the doses are less than 0.12 milligauss. Which is going to be equivalent to millisieverts in this context. So 2 transatlantic flights are 0.16. No one is taking people who are walking onto a transatlantic flight saying, oh, by the way, we're going to give you cancer on this flight. If you live in Cornwall for a year, your risk is 6.9. It's quite substantial in comparison to this. Even the average exposure to radiation, just being alive, is way more than you get from the CTPA and VQ. Next slide, please. So the question is, if the radiation exposure is negligible and similar to the exposure of normal life, and the risk is theoretical rather than proven, and there are clear harms from not doing imaging, why are we even being told to tell people about this risk of cancer? Next slide. So my suggestion is, if you really, really want to talk about this minuscule theoretical risk, then at least improve the delivery of information by not giving necessarily numbers, but giving some relative comparison to natural exposures that we get. Also, distinguishing between VQ and CTPA is just pointless. The exposure is so low for both of them. Why are you even bothering to determine between one tiny thing and another tiny thing? I think that just adds to the confusion. I personally am not convinced that there is justification to even discuss childhood cancer. That's just my take on it. Next slide. So let's go to another case. It's a 28-year-old who's 34 weeks pregnant, and she presents to triage with a significant left leg swelling. And you're asked to review. It's quite swollen, you know, it's not just a little bit of swelling, it's a lot of swelling. What investigations do you recommend? So you're wise now, you know that we can't really do a D-dimer unless you like the year's protocol, although that's for PE, not DVT. But you do start low molecular weight in the interim while you're trying to decide. So next slide, please. So an ultrasound Doppler is arranged and you see no DVT. It is above knee, it's a proximal one, you see no DVT. So what do you do next? Do you stop the low molecular weight and discharge? Do you continue therapeutic low molecular weight and repeat the scan in a week? I can tell you now, if you do that, you won't see anything, because how can a clot show itself if you're giving therapeutic anticoagulation? The third option is stop low molecular weight and repeat the scan in 3 days and 7 days. That is actually in the RCOG guidance. Or do you do something else? Okay. Which one of those are you going to do? The official one is actually the third one, but I'm going to do something else. So if you could forward. Just to remind you, what do you see on a Doppler ultrasound scan? You see the popliteal vein and you go up to the level of the groin. You almost certainly are not going to be going to get a good view of the iliac veins, basically. And pregnancy makes it even more difficult. Next slide. I am going to continue therapeutic heparin. I'm going to get pelvic imaging because I can see this big swollen leg. I can't find any other reason for it. I want to know where this proximal clot is or isn't. So I'm going to ask for an MRI scan. And this pitfall, you may think, well, that's pretty obvious. This is a massive pitfall. People get this wrong all the time. You know, because they're so wedded to the protocol. You know, we can't do well scores and D-dimers, but they're so wedded to the idea that a Doppler ultrasound, it tells us yes or no whether there's a clot there. Just have to bear in mind that sometimes imaging will let you down. Next slide. So what I'm going to just digress with a few other things that I want to mention before I finish. So yeah, D-dimers, what does it tell us for diagnosis anyway? A normal D-dimer makes a diagnosis of DVT unlikely. However, you've got to set your D-dimer before you start anticoagulants. So if you start anticoagulants, your D-dimer will immediately start to drop down. It's got a half-life of about 6 to 8 hours. You know, if you take your D-dimer after you've started anticoagulation, you may get a fake low result. The D-dimer does increase with age, and so age-adjusted levels may reduce the number of unnecessary scans. A very high D-dimer raises a suspicion of cancer. So if you do a D-dimer and it's silly high, in that case, yes, I think you need to be looking for cancer. And finally, this is really important. There are loads of different D-dimer kits out there. They have different ranges of cutoffs, and you cannot use your kit in an algorithm that used a different kit. So in the years algorithm that I showed you, you can't just use any old kit and use 500 and 1,000 as a cutoff. You have to use the one that they used. They are not interchangeable, unfortunately. Next slide. The cancer question, you know, do we look for cancer in people with unprovoked VTE? Most of you know this, but I'm just going to reiterate, there's no indication for CT screening unless there's red flags for cancer on history, examination, or laboratory testing. That is just generally, just accept that. Next slide. And whole leg scanning versus proximal only. You know, it's quite controversial, and NICE have consistently said above knee scanning, you have to do it twice. If you find nothing on the first scan and you've got a raised clinical score and a raised D-dimer, then you have to repeat it after 7 days off anticoagulation. Because as I say, if you continue anticoagulation, you will not allow clots to propagate from below the knee to above the knee to spot them. So you have to do 2 scans instead of 1, and it bases the recommendation on these 2 relatively small studies. Next slide, please. This is my last slide, I think. So just a little bit about whole leg scanning versus proximal only. So below knee imaging is less reliable. It's very much more dependent on operator skills. And most operators are not skilled at below knee Doppler imaging. If you've got loads of people who are skilled and they can do whole leg scanning, fantastic. But that is unfortunately not necessarily the reality. Most below knee DVTs, nearly all of them resolve themselves without treatment. And therefore, if you don't diagnose a small below knee DVT, you are avoiding a new risk of anticoagulation, albeit, you know, how high is that risk? It depends on the person. Above knee imaging is more demanding in terms of imaging resources because you've got to do the 2 scans, but overall it is less costly, which is why NICE recommend it. So my personal feeling is they're both fine. But if you go for the proximal only, you will diagnose less clots and treat less people. So I've sort of covered things I think are of interest, certainly of interest to me. I have got to go back to clinic later, so I won't be able to take any questions later. So I could maybe take a few now.
Thanks very much, Will. That's given everybody a lot of food for thought. It's very contentious issues around pregnancy and should you or shouldn't you. So lots of discussion there, I think, for the future. I've got one question here from an anonymous attendee. Is D-dimer useful for a 1-week post-operative hip replacement presenting with calf pain because post-surgery D-dimer is expected to be elevated? Well, would you like to answer that one? Thank you. No. The reason being? Because
it's post-surgical, so you just can't. You just cannot interpret the D-dimer. I think what you've got to ask yourself is, if I'm going to do a test, is it going to change what I do? I mean, you know, you might argue, you know, that a normal D-dimer would reassure you that you don't need to do imaging. But I would say that the algorithm, including a D-dimer and a clinical risk score, you know, that's designed for ambulatory patients, you know, not someone who's a week post-surgery. And I think if you've had a high-risk procedure like that, then, you know, and you think then the leg's swollen, you know, I think you're obliged to sort of cut out the middleman and go for the scan. That's just my opinion. I think it's the context really. And actually, this patient, you know, this patient would need a scan anyway, because if you did a well score on a person a week post knee surgery who's got some swelling, you automatically are high risk on the well score, so you have to scan them anyway. So then you say, well, what's the point of the D-dimer anyway, because you're going to scan them anyway.
Yeah, well, thank you for that. And another question from Amir Hayat. I've seen at least 2 cases in 2022 where patients came to ambulatory care with calf pain only. No clinical signs of DVT except pain, normal D-dimers, tough reasoning with radiologists as patient not responding to painkillers. Finally, scans show DVT. That, to me, sounds not unusual, but asking the question, have you come across such cases? Yeah,
absolutely. I mean, you know, these algorithms, you know, as I say, the nice guidance is geared towards diagnosing proximal DVT, with the idea that proximal DVT is more destructive in terms of the risk of PE, the risk of post-thrombotic syndrome. You know, it's geared around diagnosing proximal DVT, not of calf DVT. And if you've got people who have got those skills, who can diagnose calf DVT, I'm not going to tell you shouldn't be using those skills. But I can also say that most calf DVTs just resolve by themselves. And what was interesting in I think it was a cactus study, they basically looked at people with below knee DVT, and some of them, and it was a study. It was difficult to recruit because people were worried about not anticoagulating people with below knee DVT. But they gave people socks, and they gave people anticoagulation, and they didn't actually show that giving anticoagulation to below knee DVT improved the resolution of pain, weirdly, compared to just socks on their own.
Yeah.
And so people think, oh, if you give them heparin, it'll resolve the pain. But actually, the cactus study did not show that, weirdly, and actually didn't really support the treatment of below knee DVT. But patients with cancer and high risk patients were excluded. So I think it's a controversial area. And as I say, most of these clots resolve by themselves. And you know, what's right, what's wrong, I don't think it's that clear cut.
Just a couple of quick, well, hopefully quick ones here. This is from Taslima. Or trust radiologists, I think it's possibly, it says vet a CTPA if Welsh score is 4.5 or 3 with a positive D-dimer. Your opinion? I'm not sure if you can answer that.
I mean, basically, that what they're doing is they're following they're following the nice guidance, aren't they? Well, with a 4.5, I think that is that's a great score. So you have to image. I'm not sure about the 3 bit with positive D-dimer. I mean, it's one of those things where I think it's reasonable to vet things, but you have to be prepared to argue the case if you're really convinced your patient needs a scan, because these algorithms they're not, you know, they are flawed. So if the context of the patient means that you're not happy, you know, you've got to argue your case. But I don't have a problem in some regards of some degree of checks and balances, because, you know, they're trying to avoid unnecessary exposure to radiation. And I've just argued that I don't think fetuses are particularly at risk, but there is some risk, I think, you know, small risk to breast tissue.
Yeah, possibly one of the issues, certainly junior clinicians may have found, is requesting a radiology examination being refused because it has to be requested by a consultant. And certainly if it's out of hours or on a weekend and there's no consultants available, that might cause problems in some areas. But that's just my feeling from my own experience. So one final question. Oh, there's a couple more, but I think this will have to be the last one. This is from Sangeeta Agnihotri, I hope I pronounced that right. Should the Royal College of Obstetric Guidelines update their recommendations in light of the MBRR ACE reports of high maternal deaths?
I'm not quite sure. Yeah, I'm not quite sure the context of that really.
Okay. Perhaps Angrita could contact you after this session if they want to pursue that question. There are some other questions, but I'm afraid
in terms of Embrace, I mean, so basically, I personally think I'll finish on this.
Okay.
With Embrace is they'll look at one death, and every death is a tragedy, absolute tragedy, but they will think, right, I'm now going to apply some sort of change to the management of like hundreds of thousands of pregnancies because of that one event. You know, I think we have to be really careful about a tiny tail wagging a massive dog, and we have to be really careful about putting in unproven, potentially harmful interventions based on, on very, very small numbers of deaths. My take on Embrace is that nearly every single Embrace report has one key common factor, and that is people listening to patients and listening to people and what they're telling you. When they tell you they've got a painful swollen calf, do not dismiss them. That, if I was going to take anything from Embrace, it's not giving more people heparin, it's listening to people and making sure that you do appropriate investigations. That would be my take on it. But I'm going to shut up now.
I think that's good advice, Will. Listen to the patient, because generally they know their own bodies. So thank you very much for that. Lovely to joins us from Hampshire. So Tamara is a consultant hematologist and a consultant in hemostasis and thrombosis with Hampshire Hospital's NHS Foundation, and is Deputy Director of the Southern Haemophilia Network. Tamara has extensive experience in general haematology, but has subspecialised in hemostasis and thrombosis. She has been a leading member of the VTE Prevention Exemplar Group and represents South of England on the NHS England VTE Board. This talk really will address many everyday challenges that we all encounter, and I think this talk addresses the things that we don't always talk about, which is really useful. So Tamara's going to talk about anticoagulation in vulnerable patients, in particular risks and opportunities in frailty, people who can't afford their prescriptions, those who are imprisoned, and the digitally disadvantaged. So over to you, Tamara, and we look forward to your really interesting presentation. Thank you.
Well, thank you to Thrombosis UK for organising this. I'm endlessly impressed by the work that you're doing, and many of my patients, I love directing them to the site, and a lot of my patients tell me how much they've gained from being involved with Thrombosis UK. So thank you very much for this opportunity. And thank you to all of you that are out there listening, because I looked down the list of all the people that are attending, and wow, there's a really impressive list of experts here today. So we're all in this together, aren't we? We're all in this business of anticoagulating people, and it's not so easy, and it gets harder day by day. And today I wanted to just get you thinking a little bit about areas which I think we need to start digging into, so that the high standards that we want to see in patient care around anticoagulation are actually delivered. So on this slide, I've put at the top my current declarations of interest, and below my slightly older declarations of interest around anticoagulation for atrial fibrillation across Wessex. And I think that's important, because we've all got conflicts of interest, haven't we? We've all got our own unique perspective, and that's why you all being here today together gives us the opportunity to share ideas. And at the end, I want you to start talking, start pushing back at me and saying, well, not sure about that. So next slide, please, Joe. Thank you. So these are the three main areas that I want to focus on. We should be very proud that a lot of people are taking anticoagulants. That's good, because that hopefully is going to improve health outcomes for our entire population. That's really good, but it's also a big responsibility, which frankly we carry as the specialists involved in this area. And I think we are, by and large, pretty good at starting anticoagulation. Sometimes we're not, and there's work to do that I'll cover in this talk. But what we're not good at is reviewing or stopping it. And we know ourselves that that has a huge hidden cost to the NHS and to the people that we're looking after as well. And the last point is a really tricky one, in that we've developed a whole load of pathways and guidance which to some extent consider individuality in terms of comorbidities, but to large extent don't consider the broader socioeconomic context of the individual. And that has consequences. And I'll delve into that a bit more in a moment. Next slide, please, Joe. So this is publicly accessible data, and nowadays, thank goodness, there's a lot more publicly accessible data. And this you can get into. It's called CVD Prevent, and it's got a range of cardiovascular disease metrics, and you can drill down into what is specific to my area, or my ICS, or broader than that. And you can look at what's actually happening there. So this is a snapshot of the data for atrial fibrillation, which of course is the reason why around 3/4 of our people are anticoagulated. And what this tells us is what I think you all know, is that the majority of the people that we anticoagulate are in the older age group. And of course, that's a big group, and of course, a growing group. And as a consequence, you know, the direct oral anticoagulants, which we're predominantly using nowadays, account for 5% of the NHS drug budgets. That's a big deal, isn't it? And when we're talking about equity in terms of care provision, we need to think about that. We do know that I think it's almost half of the NHS budget is spent on people in the last 6 months of their life getting on for that sort of level. And, you know, what about the young people? So we have a responsibility to the old to get this right for them, but also to the young to make sure that we're not wasting money. Next slide, please. Okay, so we know that anticoagulation done badly destroys lives. And I think all of us will have been involved in serious incident investigations where things have gone wrong and treatment wasn't given in a timely fashion, or reversal treatment wasn't given in a timely fashion. And the consequence of that is that harm is caused. Now, of course, we can't prevent the fact that there will always be side effects to anticoagulation. One of the things I always say to my patients is that anticoagulation doesn't cause bleeding, but it will make it worse once it happens. So we can't prevent the thing that happened in the first place, but we can be more timely around the getting in there to reverse the anticoagulation when necessary, or more ideally, preventing those problems occurring in the first place, because we know that not only is anticoagulation associated with high mortality, it's also associated with chronic morbidity and permanent disability, which can be really, really dreadful to live with. And I think if I'm going to be really provocative here and say we're in danger of being complicit with this situation, because I mean, I don't know, in the last few weeks or months, I've been approached about a number of antidote related studies. So we are incentivized to participate in antidotes. We're not incentivized to participate in prevention, which I think is a problem. Next slide, please. So I just wanted to humanize this a bit and come back to sort of specific people that I've been involved with. These names are not right, but these are very particular circumstances that I personally really struggle with. So I've got a number of patients now in that much older age group who are anticoagulated for valve replacements. And quite often they bounce in and out of hospital with anemia and really struggling. Sorry if it's all quiet. I hope that's not for everybody. So these people bounce in and out of hospital with anemia, and we all get around and think, can we stop anticoagulation? And of course, when they're mitral valve replacements, we are extra especially nervous about that, aren't we? And so the system incentivizes us as well to sometimes act in ways which may not be in the best interest of our people. I'm going to come back to this issue of imprisonment later. But this was a patient that I was involved with who didn't attend an outpatient clinic, and we discharged him because we are not supposed to tolerate too many DNAs. We're supposed to be optimizing our outpatient performance. So that's what happened. And of course, many of these people end up sofa surfing when they leave prison. And he died of a PE from not having anticoagulation. Another difficult dilemma I face on a regular basis is these advice and guidance queries where people feel driven to anticoagulate people for atrial fibrillation, but often these people are in a very precarious situation with poor kidney function, chronic anemia, and I'm being asked, well, what anticoagulant is safe? And the implication of that is that any anticoagulant is safe in that situation. Next slide, please. In terms of incentives, there's another incentive which we, as I think primarily secondary care specialists, although I noticed there's some primary care specialists, we may know less about, and that is the GP contract and this QOF framework, which incentivizes achievement of targets. So there's a QOF target of 95% to anticoagulate for atrial fibrillation. Now, exceptions are allowed, you'd be pleased to hear. So your 95% target.
Tamara.
Yeah. Sorry,
Tamara. Sorry to interrupt you. We keep losing your signal. The slides are really useful because when we lose the signal, we can still read what you're talking about. So we'll let it carry on as it is. But if anybody is, I know there's messages coming through that there's a breakdown in the signal, but while the slides are up, if you could carry on. I don't know if you're aware of it, but it was just to let people know that we are aware that there is a problem, and we'll just let it go as long as we can see the slides and we can hear part of what you're saying. So sorry to interrupt you, just wanted to...
Okay, I'm sorry about that. I don't think I've got a network problem, and I am wired, but I will try and speak...
Just wanted to reassure everyone.
Okay, thank you. Okay, so this data graph that I'm showing you here actually comes from CVD Prevent, which is slightly different to the QOF data that is submitted, because QOF allows, as I say, for that exception reporting. But what you might notice in this graph is that for Black people, we aren't achieving the anticoagulation target for atrial fibrillation. And you might think that having a QOF target will incentivize us to meet that group. But of course, that doesn't always apply, does it? When one is trying to hit a target, one will often go for the low-hanging fruit, the easier to reach population. And it may be that there's something intrinsically about reaching into the Black population that we're not achieving. And I'm not confident that that target will help us with this. And I particularly wanted to bring that to our attention, because there have been so many reports out recently that show us that we're not delivering the same standard of care to people from all ethnic backgrounds. And we really need to be alert to that and thinking about new innovative ways that we can break into that space. So there's a new GP contract. The other aspect of the new GP contract that you may not be aware of is that up until recently, we've had incentives to have pharmacy interventions and pharmacists to support care, but that to some extent is disappearing, There are some areas of private provision which still work, and the transfer of care around medicines and the new medicines service still exists. So there are some opportunities, but some others are subtly disappearing in the background because they were initially introduced and then it was thought that we would put them into business as usual. So it's just locally, if you can take that back and have a think about what actually is going on in your area that you may have thought is there, but is no longer going to be there going forward. The last point I want to make at the bottom of this slide is it's really difficult, isn't it? So I have a colleague who's a lead pharmacist who feels really difficult about stopping anticoagulation for her elderly mother, even though her mother is bouncing in and out of hospital with delirium and anticoagulant related problems. We're all caught in this bind, aren't we? Because we're both professionally and personally caught up in it. Next slide, please. So that's some of the problems. I want to talk about in Hampshire some of the things that we've been doing to try and address the gaps that are coming up. So this is a service that we've introduced. It's called a telemedicine outreach service to care homes, and we support around 250 care homes now. And it's basically a virtual support centre, which we set up in 2021. To allow nursing, residential and other care homes to call in when they've got problems with the people that they're looking after to ask for help and advice. And as you can see, this service has grown massively over the last year, and I think we anticipate it's going to grow even further over the next couple of years. Next slide, please. So these are the reasons that we're getting these calls from the nursing and residential homes. And as you can see, there's quite a bit around medicines, and the ones that aren't directly related to medicines have a medicines component. So as you can imagine, falls on anticoagulations, issues with anticoagulation around infections and skin complaints, for example, there's quite a bit of anticoagulation problems in there. There's quite a bit of the staff in nursing and other care homes not understanding anticoagulation and worrying profoundly about things like if somebody's missed a dose, or if they've had a double dose, or if they've been sick, or something has happened. There is a lot of concern around that. So again, is there something that could be done locally? Because this population has a very high risk of conveyance to hospital. We have found that by introducing this service, we can reduce conveyance to 15%, but it's still quite a big, problem. And we know that our hospitals are chock-a-block full of frail elderly people who frankly would be better off at home. But we, once they've come in the door, it's really hard to support them in getting out again. Next slide, please. The other thing to sort of poke into is, I don't know about you, but for us, our anticoagulant specialist service really only operates in hours. And out of hours, there is very considerable demand, as evidenced by these calls to the telemedicine service. So as you can see here, it's actually a majority of calls that are coming in out of hours, and that may be related to timing of medications, but also the ability to access other services. At the end of the day, during the day, people might be able to contact their GP, but out of hours, they're going to try and get through to 111, and that's obviously very busy. And I don't know if you've tried it, but it can be quite hard to get through. Next slide, please. So this is another initiative that we've tried. So the telemedicine service is the outreach to nursing homes, and then we've introduced a clinical communication centre, which is about streaming calls from the ambulance service, from GPs, and from other people also within the hospital who need to get access to specialist advice to decide how they're going to manage a patient. So this particular pilot, which was within that framework, was called Call Before Convey. And as you can see, that's targeted about getting the right patient to the right clinician in the right place at the right time. And what we did, this was a pilot first week study. This is around 250 calls, the vast majority of which were from SCAS, which is our local ambulance service. And we managed to channel those calls through same-day emergency care, specialist consultant advice, an urgent community response unit, an admissions, what we call a take list, so an admissions list, which might involve acute emergency unit assessment, but not necessarily admission. And then some people who needed to come directly to our emergency department. And what we have found with this experiment is that people really, really like it. So you basically got the paramedic at the bedside making a call straight through. So an example of a call I got at 2 a.m. Was a paramedic had been at the bedside for an hour with this patient who had had a long-term disability and was in a care home, and a double dose of warfarin had inadvertently been given. And by the time he called me, he'd done an ECG. He'd been there for an hour, and he wanted to know what to do. And of course, you and I would think, "Gosh, wow, really? Was that an effective use of paramedic time?" No, it really wasn't. But at least being able to call, I could say, "No, it's okay. Look, I can see his last INR was fine. Just leave him now. You can go, and I will pick this up with the anticoagulant service in the morning, and we'll deal with this. And just make sure that doesn't take any more warfarin until we've talked to them in the morning." So that's an example of a call. Now, what has happened is that you have to be careful what metrics you collect here, because the metric that is the at the bedside time of paramedics has gone up, but the overall time that paramedics spend on patients has gone down because they're not waiting outside the hospital to offload patients. So if you decide to embark on a pilot like this, be careful what metrics you collect, because we nearly had the project closed down because the ambulance crew was spending more time on site. So next slide, please. So another area that we've been thinking about is, so we have a local prison, HMP Winchester, which is a men's prison, right next to one of our sites. And I actually went in, I had the opportunity to go into that site and talk to people about how were they managing anticoagulation, how were they supporting people with anticoagulation. And there were a whole string of issues that I'd never even considered you might need around counselling. And for example, people trying to give other people their pills deliberately to harm them. They're, really quite scary, different issues. But the prison population is largely hidden from sight, obviously. And what we probably don't realise is they have almost no health record linkage. They can't necessarily access the spine. There is no import of records into the hospital or outside the hospital. The health suite that they have is basically cells without, they have a GP and they have a nurse, but it's not really equipped to a level that we might think of as a health suite in other circumstances. Overnight, things are locked down. So the ability to access emergency care in that time is much more limited. If people need to come up to the hospital, that can be really problematic in terms of escorts. And events, visits, I think you will probably know, often get cancelled because other things happen. Some sort of incident arises within the prison and they simply can't transport the patient. And there's also a very high incidence of mental health problems. The history that you get may not always be quite reliable, in part because of drug use and other addiction problems, which they may not want to disclose. And the other issue is that a significant proportion of people, when they leave prison, are released to no fixed abode. And so they may or may not take with them a plan, but we have no ability, like we do from hospitals, to send a discharge summary to somebody that could actually support them in their ongoing care. On the positive side, when they do go into prison, they do get a health screen. And if we are able to enable video or phone consultations, then they're happy to do that. And of course, they do have the 999 access. So it's a real problem, this prison population. There's an charity enterprise called Revolving Doors, which describes the fact that these people come in and out of prison, and that their ability to access secondary and primary care is dramatically reduced. And so I just wanted you to think about that one as well. Next slide, please. So I just want to move on to refugees. I mean, I've been very fortunate to be able to host a Ukrainian refugee. And I must admit, I can't even begin to imagine how hard life is for a refugee to leave your home, to have a new language to deal with, to not be able to work. to the level that you were able to before. And that's before you've even got to thinking about how you manage your chronic health conditions. And there are a lot, you know, we've had a lot of political conversation about the boats and everything else, but we haven't had the conversation that I think we ought to be having, which is around how do we actually support people in this situation in terms of the day-to-day realities of their life. Because at least my Ukrainian guest has the opportunity to work and can get a reasonable income from that, but many asylum seekers can't and have to survive on a level of income which I can't even begin to contemplate, really. Next slide, please. So, and that leads me on to cost and thinking about costs. So this article was produced in the Pharmaceutical Journal, which talked to the fact that we have a bit of an issue around the prescription charges, and people. And I think this problem is only going to get worse, isn't it, with the cost of living? If you're exempt from prescription charges, you maybe will keep on taking your medicines, but of course. And we may find this surprising, but there's a lot of people that actually don't know about the prescription exemptions. They don't know about the prepayment certificate, and I didn't know about the broader NHS help with health costs framework until I started looking into this. So we also need to help people when we're starting them out, I think, on anticoagulation. You know, maybe I don't, it's not, obviously we don't want to be intrusive into their financial situation, but at least we can bring to their attention if there is likely to be any cost-ish barrier for you to initiating anticoagulation, then there are these resources open to you. Because I think otherwise we're storing up all sorts of problems for ourselves as well, because people won't take their preventative medicines, and that's going to increase the burden of secondary health problems. Next slide, please. And that, of course, so it's £9.65 per single prescription item. And then you get into polypharmacy. Of course, polypharmacy is largely a problem in the older population who will be exempt from prescription charges, but there are a significant proportion of younger people who are taking multiple medicines. And of course, we know that for every person, if you're taking 5 medicines, the chances are you've got at least one major drug interaction. And I don't know about you, but the number of times I stumble across people that are on carbamazepine and a DOAC, and therefore may not be getting the right amount of anticoagulation. It's a very common problem, and not all GP pharmacy prescribing systems are set up to pick up on those sorts of risks. Next, please. I want to talk a bit more about deprivation, because deprivation isn't only about the sort of financial aspects, it's also about what other barriers might be in people's way. So I had a consultation recently with a patient where actually the number he provided was his neighbour's, and we had to hold on while she walked around to talk to him. And she said, "Oh, thank you for holding, because normally he doesn't get to his appointments because he's not quick enough to respond, and unless I'm here, I can't help him because he hasn't got a phone, and it's his personal choice in this case. He doesn't have a phone, but he can't access." And although many people do have that sort of digital access nowadays, it's not everybody, and we've got these pockets. It's not always obvious where that deprivation is going to be in. So we're locally looking at those particular sites of deprivation and thinking about how we could do better in those particular, in this case, that little red area community. Next slide, please. The other issue, and I suspect you've all found this, is around people taking warfarin. Warfarin, keeping time in therapeutic range, has got harder and harder because we've sort of got rid of the easy people and put them onto DOACs. And so we're left with the much harder group, particularly the valve patients, who can be very, very tricky to manage in that older phase of life. So, and this group of people also, it can be very difficult to get up to hospital. So during COVID, we tried something out. We tried doing finger prick tests in the car park outside the haemophilia centre, and that actually worked really well. And then we thought, oh, well, this is interesting. Let's have a think about whether we could do this in a different way. Next slide, please. So what we thought we'd do, we put in a bid to NHS England, was then NHS Digital, to buy some Coagucheck devices so that we could loan out to the community, because many of these people couldn't afford them. So we've now loaned out 72 devices to people, and we have an anticoagulation support worker who goes out and trains people on how to use them and talks to them about how they get the results to us, and then we help support them with their dosing. And next slide, please. So some examples of things that we've managed to achieve, and we've yet to compile the whole report, but as you can see, in some people we've managed to significantly increase time in therapeutic range, and we're reducing the green footprint also of people. And the latest thing that I'm quite excited about is also how we support the prison better in this regard. Next slide, please. So the last thing I want to talk about is appropriately the last, is what are we doing about the last phase of life? I think we are guilty of anticoagulating people to death. And I think we could do better in this regard. If you look on the NHS website about when we should think about people being in a palliative care phase of life, that includes people who are generally frail and have coexisting conditions that mean they are expected to die within 12 months. And I think you, like me, would probably recognize that there's a lot of people on anticoagulation in that group. And it's difficult for people to deprescribe, isn't it? And there's a lot of reasons for that. It's that people don't have time. They're not always clear who is responsible for doing that. It's the specialist that initiated it, and they are anxious to stop it. And that uncertainty means that the default is to not stop. We haven't always, when we set out on the journey, been clear about the goals of care, what it is we're trying to achieve. And I think sometimes people think we're trying to achieve more with preventative anticoagulation than we are. And there's also this whole very difficult bit about, well, does that mean we're just giving up? Does it mean we're saying that the frail elderly aren't worth medical care? Which of course is all wrong, isn't it? Absolutely they are, but it's about getting the right care. Next slide, please. So these are the questions I wanted you to consider, and I'm guilty of this myself. I needed to do this talk for myself, to be quite honest. A few years ago, I worked with a team to produce a film called Starting Anticoagulation with Jack, because Jack was the name of my son. But have I ever made the film about stopping anticoagulation? No, I haven't. Have any of you? Is this something we should be trying to do together? How could we do better in that last phase in life in particular? Last slide, please. So these are some of the brilliant people that I work with that I just particularly wanted to acknowledge. Sarah, who is my consultant colleague, Liz from the CCG, Sam, who runs all of virtual outreach, Udi, who's on maternity leave, but helped launch the community project in partnership with Neve, my specialist nurse, and also Fiona Maxwell, who's a public health doctor, shortly to be consultant, who helped me with the broader inequality piece, and Sarah Noble and the team who run the Call Before Convey pilot. So thank you very much indeed. I'm going to pause there. I've left hopefully nearly 10 minutes to pick up on any questions.
Thank you very much, Tamara. That was an excellent presentation. Unfortunately, my internet is playing up something terrible. I thought it was everybody, but I think it's just me. If I stop speaking or if I disappear, and Joe is going to step in and take over. But I think you raised some really important issues, and certainly having had patients who were asylum seekers who didn't speak English, and the difficulties around just trying to meet with family and explain to them why their relative had to go on to an antibiotic and it's a very rewarding.
Andrea, I
And
think
you're
I'm just going to.
for positions.
I
Sorry,
think that's right. It's sort of really hard to follow the sentence.
I can't hear you.
No, but I think basically, I think what Andrea's saying is that was an inspirational talk, and so
Over.
thank you so much, Tamara. That was amazing. And as you can see in the chat, there are so many comments which have come through. One thing that struck me was you work with so many different agencies and individuals across these pathways. Two questions really. How do you initiate that? And did you find there were wins of working in or the challenges to overcoming so that you could work together, for instance, with the prison staff?
So I think I'm naturally curious, and I love meeting new people and hearing about their experience, because I'm only one person. And the only way that we improve care is by being all in this together. And that's why I wanted to talk today, to tap into this vast network of skilled people who can start being more curious in their area. I think it's about, you know, where the opportunities arise. So it's like when you're dosing somebody in a prison, what is it that I could do differently? If you encounter a refugee, to what extent am I meeting your needs? And then it's just about sort of spreading that, and then thinking about who might be accessible to you in your local community. Who could you ask? Who might be able to ask someone else? Who might be able to ask someone else? Who then gives you the opportunity to engage. So I'd say, I don't know if any of these particular ideas resonate with you, but it's hard to kind of go out there and ask what is going on around you. Because people are delighted to collaborate, I've found. They bite your hand off to have a little bit more expertise.
That is brilliant, thank you. And did you find any opportunities where actually some more information, so for instance, in somebody perhaps with a mental health issue or being released from prison, could be given either some information that may just empower them slightly to access or to understand certain things that would help them to continue their anticoagulation or to get help with their anticoagulation? Was there anything you could do on that side?
Yeah, so this is something that I'm learning all the time, is that so one of the things I always do now before I finish a consultation is to say, so what have you heard that felt relevant to you today? I always write my output of my consultation to the patient. I always talk to them, and I try and talk into what their particular motivations are at this point in time, try and weave it in like a golden thread to where they are, and also be realistic, because many people have really hard lives, and you need to help them weave in why this might be important to them on a daily basis. Many people, for example, are on a self-destruct pathway. And if you just say, this is going to make you live longer, that's probably not going to work. So you need to say, okay, so what is it that matters to you right now? You know, who are the people in your life that you need to be there for? You know, it's tapping into what is their priority right now, and in what way you could support them. And I'm lucky enough to have psychologists in my team. So when they run aground, I've got people that can help them break out of what is sometimes a really poisonous cycle.
That's really interesting, because I was on a talk a little while ago where somebody said, you know, one of the questions that he tries to open up with is, what's important to you? And actually, if you start with something like that and end with yours of what have you heard, you are really surrounding that talk with as much help as is possible in that short consultation, but relevant, very, very relevant to the individual.
Because I think if you step back from this and think about, why do we decide, it's a bit philosophical this, but why do we decide to make changes in our life? And the answer is, somebody said to me once, nobody listens to advice. And I thought, well, that's quite interesting, isn't it? But the truth is that we make changes in our life because it feels the right thing to us, not because somebody told us to, by and large. Although my Chinese sister-in-law would tell me that in the Chinese community, they're far more motivated to do what they're told. But but actually, by and large, you've got to tap into why is it that they want to choose to do it for themselves.
Something that I know has been mentioned in the chat, and we have lots of questions on, you managed successfully to secure the funding for some Coagulacheck machines. How difficult was that, or what was your magic in doing this?
So the real difficulty with central NHS digital money is that it comes out often at really short notice and with a very specific remit. So the trick here is to have some things ready to go that you think you would like to do, and to make sure that whether through your procurement team or your co or somebody else, that you are getting alerted to these opportunities as they come in. I happen to lead the improvement team, so I get alerted to these opportunities, so I can go, oh yeah, that I can make the connection, that matches with that, could we do that? So it's kind of being alert to those funding drop opportunities. There's one out at the moment which finishes at the end of the week, which is about patient engagement. That's more about portals to feed into the NHS app, but it's like, well, is there something we could weave into that? Can we tell the story of why that is meeting their requirement? And so I've been on a call this morning thinking creatively about how we match that funding ask. But some of these sums are significant. You know, that's 500 grand potentially per trust.
Yeah. So teamwork, looking ahead and having a plan that you, as soon as there's an opportunity, see how you can weave it in. Thank you. Another good question here was about that you mentioned about the 90% compliance rate in also INR rates in the Black community. And do you know if there's any training or anything, any further data being collected to address this, to understand the potential reasons why and how it might be readdressed?
I wish I could tell you the answer to that, but I think it is the same problem as we know we've got in maternity services and pretty much every other service we deliver, is that I'm afraid we are still targeting to a white British demographic, aren't we? And we're not thinking more broadly. I mean, I was slightly horrified when one of my midwives said to me that the APGAR scoring system, I think for new babies, still said, is the baby pink? You know, we've got a long way to go to know how to reach properly into these different communities, and that's going to need a lot of thought, and I'm not going to be the expert clearly in this area. So what I try and do is I've work with the people on my team who would have broader insight into how we can do that. So that's get me to talk another year and I'll tell you what I've done.
Well, for now, I'm aware of the time, but thank you so much, Tamara. Really interesting, inspiring, and I'm sure lots of people will go away with lots of ideas and hopefully share with their community as well. As we've mentioned before, if you have questions, in the, I've got to work out the lounge, there is an email faculty. If you email it through, it comes through to Thrombosis UK, and we will try to get answers wherever possible. But for now, thank you so much, Tamara. And now I'm very pleased to welcome Baris, who is here from the North Bristol Trust. This is our final session for the morning, but Baris is a vascular surgeon specialising in diabetic limb salvage and deep venous reconstruction and thoracic gosh, this is going to challenge me now, endovascular surgery, as well as open aortic repair. He is a fellow VTE champion, along with Sue Bacon at the NHS North Bristol Trust, and sees firsthand the long-term harm and impact that blood clots cause. Baris is going to talk to us about the role of vascular surgery in VTE, but also in the how, the when, and the with whom. And it's a talk that I know I'm really interested and looking forward to. So without any further ado, I'll pass over to you, Baris. And if you'd like to share your screen, if you have slides.
Yes, I'll just do that now.
Thank you. Yeah, if you can presenter mode. That's it. Perfect. Thank you. On basis you can, we will try to get answers wherever possible. But for now, thank you so much, Tamara. And now I'm very pleased to welcome Baris, who is here from the North Bristol Trust. This is our final session for the morning, but Baris is a vascular surgeon specialising in diabetic limb salvage and deep venous reconstruction and thoracic this is going to challenge me now, endovascular surgery, as well as open aortic repair. He is a fellow VTE champion, along with Sue Bacon at the NHS North Bristol Trust, and sees firsthand the long-term harm and impact that blood clots cause. Baris is going to talk to us about the role of vascular surgery in VTE, but also in the how, the when, and the with whom. And it's a talk that I know I'm really interested and looking forward to. So without any further ado, I'll pass over to you, Baris. And if you'd like to share your screen, if you have slides.
Yes, I'll just do that now.
Thank you. Yeah, if you can
Right.
presenter mode. That's it. Perfect. Thank you.
Hi, everybody. Yes, as Joe says, I'm a vascular surgeon, and I have an interest in the management of patients who have had deep vein thrombosis and venous disease in general. And this talk is mainly going to be focused on the consequences of that to the limb and what we can do about it. So understandably, the focus historically when thinking about venous thrombosis was about trying to prevent or treat pulmonary embolisms, and that was entirely valid. But in the last sort of a decade and a half, there's been an increasing focus on the consequences to the limb, and specifically about trying to prevent a phenomena called post-thrombotic syndrome, which isn't very well defined, but essentially it's anything from mild swelling through to pain in the limb, particularly with exercise, through to skin damage, through to full-blown ulceration. And post-thrombotic syndrome is important because it's been shown to have quality of life impacts that are akin to heart failure or chronic obstructive pulmonary disease or diabetes, and can often afflict quite a young population with sort of therefore impacts to wider society. In terms of the proportion of patients getting post-thrombotic syndrome, the range is between 1 in 5 to 1 in 2, so 20 to 50%. And we know that certain factors increase the likelihood of getting post-thrombotic syndrome. So this is deep vein thrombosis involving the iliac veins, a high body mass index, and actually the severity of symptoms and signs on presentation as manifested by the Villalta score. And we know that just 2 of those things that I've mentioned increase the risk of a post-thrombotic syndrome 5 to 6-fold. In patients with iliofemoral deep vein thrombosis, we know that about 50% will go on to develop a post-thrombotic syndrome. And they're the main focus of patients who are seen by vascular surgeons. Now, in terms of trying to prevent post-thrombotic syndrome, it's very clear that anticoagulation is the mainstay of treatment. And we know from previous studies that patients that have effective anticoagulation are more likely to have a healthier limb, i.e. less likely to have a post-thrombotic syndrome. And I think this study had shown that if INR was in range 80% of the time, that the post-thrombotic syndrome risk was 1 in 5 versus 1 in 3 in patients when it wasn't. And we know now that anticoagulation with DOACs is likely to be more effective in preventing post-thrombotic syndrome than warfarin. And so hopefully this will all address the potential problems that we see in the community. But what we also know is that most of the other interventions that we have medically probably do not make much of a difference in terms of impacting on post-thrombotic syndrome incidence. And certainly when we look at the medical therapy arm of interventions for acute DVT, so procedural interventions, we see very high rates of post-thrombotic syndrome. So, for example, in the CAVA study, it was 45% at 39 months. In ATTRACT, it was 51% at 2 years. CAVANT, it was 55% at 2 years and 71% at 5 years. So whilst those studies did not necessarily use DOACs, it does suggest there's a long way to go in terms of trying to prevent this phenomena. But why does post-thrombotic syndrome occur? It's essentially a phenomena of venous hypertension or congestion in the limb, which can be either from damage to valves leading to reflux in the veins, or as you can see, this is a histology specimen where the vein is fully occluded or has just small channels of flow through it. And the diameter of veins has a bigger impact on flow than it does in arteries. Now, there's been therefore a desire to intervene on patients with iliofemoral deep vein thrombosis. But historically, this was limited because, as you can see by this, doing open procedures to try to retrieve thrombus led to quite significant morbidity. And it was nothing like these beautiful sort of pictorial diagrams that you're seeing here. It's messy, and the morbidity of these interventions is quite significant. And these never really took off except for some extreme situations. Modern interventions for iliofemoral thrombosis essentially can be divided into catheter-directed thrombolysis, pharmacomechanical thrombectomy, and mechanical thrombectomy. And we'll go through each of these in turn. Catheter-directed thrombolysis is the introduction of a multi-side hole catheter into thrombus directly using sort of radiologically guided access, typically from the popliteal vein behind the knee. And these catheters are special. They have a valve at the tip so that then thrombolytics are bolused, then infused into the thrombus to try to effectively melt the thrombus away. And this is a process that usually takes 1 to 3 days. And the obvious concern is about the risk of bleeding with this. So there was a move to try to shorten the time that of the intervention, but also reduce the dose of thrombolytics. And again, we've been using pharmacomechanical strategies, so devices that more aggressively bolus the thrombus. So this particular device is called AngioJet, and it pulse sprays the thrombus with the thrombolytic. There's a dwell time, and then the same device is used to aspirate the thrombus back in. And the idea was that with this strategy, we could usually turn a 2 to 3 day intervention into a 24-hour intervention, because typically it didn't do enough, and we still had to do catheter-directed thrombolysis afterwards. We now have more sophisticated devices that can remove thrombus. So what you see on screen left is called the ClotTriever, and it has an element that cores out the thrombus and then a collection basket above it, which you can see here. And this allows us to remove all the thrombus in a single session. And I'll show you later on in the presentation the sort of thrombus that comes out. The device on the left is called Penumbra Lightning 12, and this is essentially a sophisticated vacuum cleaner, which allows us to directly aspirate thrombus from veins. And the thing that's sophisticated about it is to minimize blood loss. It can detect when you're just aspirating free-flowing blood, and has mechanisms to reduce that. And both of these devices are looking very effective, and we've been using them in the last 6 months in North Bristol. This was given us the added advantage of sort of making it easier to deal with the sort of the international shortage of thrombolytic agents. So once the surgeon and the radiologist have sort of percutaneously and minimally invasively removed the thrombus, one thing we have to highlight is that typically we will find compressive syndromes in the vein. So what you may have heard about called the May-Thurner syndrome, for example, where the right common iliac artery compresses the left common iliac vein. This is actually a very common finding, but associated with it, we also find some evidence of chronic damage to the vein. So the patients probably had subclinical deep vein thromboses that's led to fibrosis and occlusions of veins. Interestingly, using standard X-ray procedures, we can't see where these narrowings, blockages, and damaged veins are, but we now have a tool, in fact, we've had it for a while, called intravascular ultrasound, which allows us to really identify these abnormal segments. And these segments are then treated with essentially ballooning, so angioplasty or more specifically venoplasty and stenting. This is just a slide to illustrate the sort of pictures that we get from intravascular ultrasound, where we can really see the vein from the inside out with a great level of detail. And this has meant that we actually now treat a greater length of vein with stents than we historically used to. And we think this has led to improved outcomes. And in this slide, you can see an example of the balloons that we use, which are big balloons, much bigger than the balloons we use in arterial surgery. And the dedicated venous stents, this is a Zilver venous stent, which was the first dedicated venous stent. And these stents have a higher radial force than arterial stents, which is required in the veins. And this particular stent has quite a nice flexibility, which means that unlike in arterial disease, we can stent below the inguinal ligament, which is essentially enter into the groin without too much in the way of adverse consequences. And I thought I'll just use this slide to illustrate what we see with our X-rays. This particular image was taken after about a day of catheter-directed thrombolysis. You can see that the vein is still full of thrombus, and this patient needed the full 3 days of thrombolysis in order to get a clear vein. But afterwards, we identified that there were indeed areas of damaged vein or compressed vein. This point here is where the artery crosses the vein, and you can see the balloon that's used to stretch the vein open wasting. This is how we describe it. But there were other areas of narrowing further down, so not in the classic May-Thurner position. And you can see this picture over here on the right compared to the one on the left, what we achieved by opening the vein up. And one of the interesting things is how quickly the patients recover. Although we're doing the procedure to prevent a post-thrombotic syndrome months or years later, in reality, the patient's leg becomes near normal by the following morning after the intervention. So we do get a sort of an earlier return to work or other sort of societal functions and a better quality of life early with these approaches. So there's now clear recommendations to at least consider the use of thrombus removal strategies in patients with iliofemoral thrombosis, but to not use it in thrombosis limited to the femoral popliteal or calf veins. And this is because when we meta-analyze the trials that have looked at this, there is evidence that we prevent post-thrombotic syndrome, particularly the more severe, moderate to severe forms of post-thrombotic syndrome. Yes, so if you have a patient with an iliofemoral deep vein thrombosis, you should consider referring on to a vascular service that can provide these sorts of interventions, or at least discussing these patients. I wanted to just show this graph. So this is actually the North Bristol outcomes for this intervention. And the y-axis on the left is patency, with 1 representing 100% patency and 0 no patency. The 3 lines that you can see, the red, the green, and the blue, the red line represents we do the intervention, and patency if we don't do anything else. So 2/3 of patients would maintain their patency that way. But what we want to emphasize that quite a lot of patients, to get to the sort of 85–90% patency rates years down the line, require a re-intervention. And this can be something very simple like a local anesthetic procedure to stretch open a stenosis or a narrowing in the vein, or a full-blown thrombosis of the stents, which requires another general anesthetic intervention. We do quite detailed surveillance on these patients. And what I do want to kind of emphasize on the slide is that even if there is a re-intervention, typically we can then maintain patency for a long period of time. And that's because venous stents endothelialize. So once they endothelialize, typically they seem to be fairly resistant to thrombosis. And look how good these results are with sort of 85–90% patency rates years down the line, compared to 66% patency at 6 months for example, the Cavent trial. And we think that's part of the reason why the results on those trials aren't as good, because they weren't using intravascular ultrasound, and they weren't doing venoplasties as often, and they weren't stenting veins, which we think is crucial for good outcomes. One of the drawbacks to intervention, though, is the increased bleeding, major bleeding that we observe in the historical trials. And even though overall the rates of bleeding are only 2.5%, and despite the fear of it, there were actually no cases of intracranial bleed in the randomized trials that were looked at. This is an anxiety, and it used to stop a lot of patients agreeing to have the intervention. So after counseling, they would choose to take their chances without an intervention. And this is why we think that these mechanical, no thrombolytic free strategies may help us to provide this care to a greater number of patients, particularly more elderly patients who have an impact on their quality of life, which is avoidable. Because we used to be more nervous about delivering these interventions with thrombolytics to our elderly patient cohorts. This is just a case of a patient who had undergone catheter-directed thrombolysis and ended up thrombosing their stent, which you can see here, when their anticoagulation was held for a colonoscopy without any bridging. And you can, if you look carefully, see that this darker inside the stent on the vein than on the other side. So it was interesting with this patient, after the 3-day process of catheter-directed thrombolysis he'd had about a year and a bit earlier, he did not want to go through that again. So we treated him with the penumbra, the sophisticated vacuum cleaner, as I described it. I'll just show you, this is the pictures that we took prior to treating stent occlusion. So the contrast that we used goes up to the stent, but the stent itself does not fill within contrast, so it's fully blocked. This long thing here you can see is the penumbra lightning catheter, and we've gone through it, sucking out the clot already, and we got a picture that looks like this afterwards. So some flow through the stent, but it's not perfect. This is the sort of thrombus that we retrieve, so fresh thrombus aspirated out of the stent. So very effective, very satisfying. This gentleman actually had some stenoses in the stents, which we then, having identified them with the intravascular ultrasound, then ballooned open in this series of images. And these are the final pictures after this intervention. And this whole thing took about 1 hour and 15 minutes to get full clearance of his stents. And, this is an individual that is able to, run 5–10 kilometers with now. And he would not be able to do that, we don't think, without this intervention. I just wanted to show a separate picture. This is the sort of thrombus that we can take out with the ClotTriever device, with the coring element and the retrieval basket. And here you can see that there's more, some elements of chronic thrombus as well as the fresh acute thrombus. And this is relevant because it means that we can intervene later down the line, several weeks down the line, rather than in the sort of the hyperacute phase of the thrombus if the patient's symptoms persist. And I wanted to emphasize that because NICE guidance is that you should intervene on patients with symptoms less than 14 days. But actually, with these more modern strategies, we are able to deal with thrombus 3 to 4 weeks even down the line. And this gives the patients sometimes a chance to think a little bit, see if their leg is showing signs of recovery with conservative measures like elevation, TED stockings, and really good anticoagulation. And you know, we admit a lot of patients with iliofemoral DVT, and 2/3 of them actually get such a good response acutely to really 1 milligram per kilogram of enoxaparin and BD dosing, very aggressive leg elevation and TED stockings, that we effectively can avoid having to do something. But if they're not responding to that intervention and now their symptoms are sort of 3-4 weeks down the line, we can still think about doing something for them. So again, no harm if you've got a patient outside of that 2-week window set by NICE, please talk to us and we can see what we can do. And this is just a few slides or so to say we get a spectrum of disease. And in our practice, we tend to not intervene on patients who've got rapidly improving symptoms or mild to moderate only symptoms, because although we can't say it as an evidence-based statement, in our anecdotal experience, those individuals don't seem to go on to develop post-thrombotic syndrome. So if, for example, you refer to us, we would try and see these patients within 24 to 48 hours in our vascular hot clinic. We'd perform a formal ultrasound, and if they had significant symptoms, we would admit them and go through the regime I described, which also involves getting some cross-sectional imaging. And when we talk about aggressive elevation, we really do mean it's aggressive. It looks ridiculous if you walked into the patient's room, they were sort of almost angulated at 45 degrees. But it does seem to help with managing them acutely. So let's say none of this happened, or the patient developed a post-thrombotic syndrome with best medical therapy. What can we do then? Well, again, we can elevate, compress, teach about skincare, encourage weight loss, encourage exercise, use compression devices. But very often with established post-thrombotic syndrome, other than compression hosiery, which I think does help, we don't necessarily make things a lot better. And that's because of the way these veins have become. So this is the actual inside of a post-thrombotic vein. So if the problem is in the iliofemoral segment, we may be able to treat those patients with deep venous stenting again by recanalizing their veins, using radiological strategies, and then stenting them open. Just as a general comment, if you have patients with leg ulceration, the guidance is that they should be referred in to see vascular specialists, actually, if there's within 2 weeks of an ulcer really developing. So again, if you've got someone with really bad post-thrombotic syndrome, please don't hesitate to refer in to us, because there's things we can usually do. Again, I just want to mention that historically, despite these beautiful diagrams, the open operations to fix these problems were not very effective and were associated with very significant morbidity, so never came into vogue. And these things are now reserved for patients who failed percutaneous minimally invasive surgeries and with quite severe post-thrombotic syndromes. I wanted to just go through a few cases just to kind of illustrate what we mean. So in this case, this was a patient with a left leg post-thrombotic syndrome with quite bad swelling and claudication, which is pain with exercise, even difficulty climbing stairs after postpartum DVTs that were otherwise fit. Our imaging demonstrated that the veins were damaged or compressed in the iliac segments with webbing into the common femoral segment, and that unfortunately their femoral vein was also scarred, but that they had a satisfactory profunda vein, which is not ideal, but enough to consider an intervention with venous stents. And this is the pictures we took, our venograms prior to the venoplasty. You might go, well, that doesn't look too bad, but I want to highlight a few things. So there are collateral veins coming off here, and in normal veins, you shouldn't see any of those. And once again, if we look at this intravascular ultrasound, so this is now a moving image, as I scroll through, you'll see that these veins, this vein is narrow. It's much narrower than it should be. And in parts, essentially stenosis down to barely having a lumen. And this is an illustration of how the venograms underestimate the severity of the venous disease, and why this tool of intravascular ultrasound is very useful. That's the profunda vein coming off there. So after we balloon the vein open and then stent it open, the stent is very faint, you can't see it. This is the change in the image that you will see. And you'll see that now there's rapid clearance of contrast and the collaterals have gone. And this patient had a very good response to their intervention. And I have to say, in clinic, this is my sort of favorite patient group, because the change in their life is quite significant, and they really appreciate what's been done, and it's very satisfactory. And I can't say that's always true of vascular interventions. And this just to show you the difference with the intravascular ultrasound afterwards. And you can see here the vein is stented and widely open, so it's wider than before. There's no issues within the stent itself, just to show you the difference between the sort of widely open vein and the first image that you saw. In this second patient, slightly more complicated, they've got bilateral post-thrombotic syndrome with recurrent VTEs, established on rivaroxaban. They again had inflow from their profunda veins into their common femoral and iliac segment. But we knew that they had iliac disease bilaterally. I'll just show you again the pictures of what things look like before the intervention, with contrast stopping at this point here, some collateral veins here. Similarly on this side, contrast stopping here with then collaterals taking over. This is a picture on the patient's left with a balloon up to show you the kind of body's attempt at collateralization. Unfortunately, these collateral veins, because of how narrow they are, can't take on the same amount of flow as a single healthy normal diameter vein. And again, this is after the intervention by crossing with wires, ballooning and stenting. See the marked difference with rapid clearance of contrast outside of the leg, effectively decompressing the leg. And so you can see a similar thing on the left-hand side here. So again, a very good technical result. And this patient who was suffering with recurrent leg ulcers then maintained their healing afterwards. This is just one more example of a sort of before and after side by side, with collateralization and an occluded vein here, but with rapid clearance of contrast on this side. And this individual, this was a referral actually from the sort of south coast, so out of region, and they had essentially been unemployed for a long period of time after their DVT, but after the intervention are back at work, just socializing more, happier. So it's very satisfying again. But one of the sad things here was that because venous disease is not life or limb threatening to the leg, so if you have established post-thrombotic syndrome, I think this patient had to wait over a year after the decision to treat to have their intervention, and I think that's something that's not very satisfactory and much talked about in the sort of vascular community. And just to show an even more complicated reconstruction, this patient again was a referral from Wales, so out of region, and they had during their law studies in Liverpool had a deep vein thrombosis of their iliac veins and had bilateral post-thrombotic syndrome. And the background to this was that they had a congenitally abnormal IVC. And we've ended up reconstructing both the iliac veins and their IVC with stents. And again, quite a satisfactory result. These are very challenging cases. I think it took us about 3 to 4 hours to be able to get across these occlusions. But it pays to be persistent, and we've got a good result in the end. So I just, before kind of moving on to questions, I want to say that what I hope that this presentation emphasizes, that if you have patients with iliofemoral deep vein thrombosis, or even suspicion of iliofemoral deep vein thrombosis, i.e. they have whole thigh and leg swelling, you should consider referring to your local vascular service that provides these sorts of interventions. And it may be that if your local vascular service doesn't provide it, you consider talking to your nearest vascular service that does, because there are centres around the country that perform these procedures. And certainly there's no harm discussing these patients and thinking about intervention. And if you you have patients with established post-thrombotic syndrome, they have already got it, again, please consider referring to vascular services that provide these sorts of interventions, because they can make a tremendous quality of life difference to these individuals. So yeah, that could be us or other centres around the country, but we're quite keen to receive these referrals. And another sort of comment to say is that, unlike many other areas of surgery, the group of specialists who manage these patients across the country are very collegiate. We talk to each other. We're very happy. We sort of often MDT across centres to decide what to do. So it's a very kind of positive area in terms of collegiate working.
Thank you so much. That was incredibly interesting. And as you say, extremely satisfying to see people benefit from these operations that change their quality of life and what they can enjoy in their life. Somebody in the chat has said, very interesting presentation, made me think more about my hospital referral criteria for thrombolysis. So, you know, really hitting the mark. A couple of questions. I know we're really short of time, but in the questions, somebody has asked, is it common practice to remove stents, much like IVC filters, if there's a prospect of a defined duration of anticoagulation? Or if a stent has been required as part of management, then presumably the vessel is too damaged to allow discontinuation of anticoagulation. What are your thoughts of that?
So venous stents are not removable, so they go in. And I sort of mentioned it in the talk. One of the nice features of venous stents is that they endothelialize, so they do get covered by the body's natural lining. And so that actually gives them some resistance to thrombosis later on, which is why if we can get the patient through the first month and a half after the intervention, quite often we can maintain patency much easier. And part of the reason why some of the early re-intervention patients then maintain patency is because once we've got them through that period, the stent is more resistant to thrombosis, but they can't come out once they're in. And that's why it's important to use dedicated venous stents. If you use arterial stents in this setting, they usually fail, and once they're in, they can't come out.
Wow.
In terms of decision-making about anticoagulation, it's actually very interesting. Most of the time, what we say is that the decision-making should be made as if the stent isn't there in the long term. So once it's in, 6 months down the line, if normal hematological practice would have been to stop anticoagulants, then we usually would go along with that. And that doesn't seem to be a problem. Whereas if it was a unprovoked DVT with ongoing risk factors, etc., then we would maintain anticoagulation, but not because of the presence of the stent, because it would have been continued anyway. So definitely don't just keep anticoagulation going forever just because of a stent. I think if that was the case, I would put less stents in, because I would be anxious about forever anticoagulation automatically. There are scenarios where someone you might have stopped anticoagulants has had recurrent problems with a stent, and then you may have to have a kind of a formal discussion between the vascular surgeon, the hematologist, and the patient to decide what to do. But actually, that's surprisingly rare. Most of the time, it's pretend the stent isn't there. What would you do with anticoagulation?
Okay, brilliant. Thank you. I know we're out of time, but would you be happy if people do send in any questions that I can forward them on to you? And thank you. I know there's also one about different centres, and I'll liaise with you so that we can hopefully share the network of centres around the country so people understand where they are. That brings this morning to a close. I think you can all agree it's been a terrific morning. Thank you to our chair, Andrea, who's had IT issues, so couldn't join us for the last hour. To all our speakers who have been so informative, inspirational,